Hi, everyone. Welcome to the 8th annual MQ Mental Health Science Festival. Apologies for the delayed start. We had some technical issues and we were all stuck backstage. We were not having Prosecco's before we start, I promise. We were just unable to get ourselves onto the platform. Hopefully you can all now see and hear. So welcome to this science festival. MQ Mental Health Research is a leading global mental health charity that invested over $25 million into research across the translational spectrum and care continuum around the world. This year's festival has been organized by an international and multidisciplinary panel of 8 people from 6 countries, collectively bringing a wide range of experience, including mental health activists, academics, lived experience experts, policy advisors, and so many more, all led by the chair of this year's MQ Mental Health Science Festival, Helen Fisher. The aims of this year's festival are convening different disciplines and sectors around the world to collaborate and share research and learnings to progress the field of mental health science. And the focus of today's particular topic of 5 is the fact that almost 1 billion people worldwide have a mental health or substance abuse disorder. And it's only through cross-sectoral collaboration that we can improve mental health for all. The talks and panel discussions from today and across the 5 days will be recorded and will all be made available on the MQ YouTube channel, which will be popping up in the link in the chat very shortly. We're excited to have an international and diverse audience here today and throughout this week, including people with lived experience of mental health and researchers from different career stages, mental health practitioners, representatives from NGOs, community organizations, funding organizations, and so much more. You'll notice that throughout the festival, we'll be referring to individuals on all of the panels without using professional titles. And this is to really make sure that everyone in this space feels an equal contributor. So we hope that you sense that belonging to the festival. Please do remember when commenting in the chat that we do have a diverse audience from around the world watching today, including people with lived experience of mental health. So please do be kind and respectful in all of your words and comments that we use. Throughout this week, we'll be discussing topics that some people might find challenging or upsetting. If you feel that you need some support, please do check out MQ's Get Help page on our website, where you can find a list of resources and helplines. And do feel free, if you have to drop out at any point, to take some time to do that. If you're on Twitter or other social media platform, we're really keen to hear your thoughts on the talks and discussions. So please do use the hashtag MQ Science Festival for all of your social posts, and let's spread the conversation as far and as wide as we can. During the talks and panel discussions, we're in the Zoom webinar format, so your camera and your mic won't be working in those, but you can type into the chat, and if you've got any questions for any of the panelists, you can put those into the Q&A box, and those will be passed through to the chairs of each of the symposium. Later today, you'll be moved into breakout rooms where you will be able to access video and mics and be able to share your thoughts in those rooms. For now, I'd like to encourage everyone to introduce yourself in the chat by just putting in your name and social media handle, which part of the world you're joining from, and what you think the biggest challenge in cross-sectoral work in mental health is. So name, where you're joining from, and what you think the biggest challenge is that we're facing on this topic. Do type your questions in the Q&A box throughout. I can see some we've already used that, and that's what managed to get us out of the backstage area. I'm going to stop now and hand over to our chair of the conference, Helen Fisher. Helen Fisher is a professor of developmental psychopathology at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. Helen's research focuses on early risk factors that predict the development and persistence of psychotic experiences in childhood. We are delighted that Helen has been an MQ Fellow, and she's also received other national and international awards, including a recent Emerging Leaders Prize in Adolescent Mental Health from the UK Medical Research Foundation. We're excited and delighted to have Helen as the chair of MQ's Mental Health Science Festival this year. Helen, over to you.
Thank you so much, Lee. It's an absolute pleasure to be here, and a really warm welcome to everyone to this very first session of the MQ Mental Health Science Festival. So as Lee said, this first session will focus on cross-sectoral collaboration and use of evidence for influencing policy, practice, and change in mental health. I'm delighted to introduce the absolutely fantastic Lade Smith, who's going to chair our first session. Lade is a consultant psychiatrist at the South London and Maudsley NHS Foundation Trust and is a clinician with a really strong academic focus. She's been voted both as Woman of the Year and as Psychiatrist of the Year. And without further ado, I will now hand over to Lade to introduce us to the new first speakers. Thank you.
Right, so thank you to Helen, and thank you to the organisers for this fantastic festival. It's going to be going on all week. And well done those of you who managed to get a ticket, because I understand it is completely sold out. And I think that tells us how important and how mental health is to everyone across the world, and how vital it is that we have some really good, strong evidence base to support good outcomes going forward. So it gives me great pleasure. I have the honour actually to introduce our very first session, and we have three fabulous speakers. I will urge you please to go to the website and have a look at all the things that they've done. They're incredible speakers. We have Ricardo Araya, who is a Professor of Global Mental Health at King's College London. And he is going to be talking to us about he has incredible expertise in the development and implementation of simple and affordable intervention to treat mental disorders. That's particularly in resource-poor settings. Khalid Saeed is our second speaker, and he is a regional advisor for mental health and the substance use program at the Department of Non-Communicable Diseases and Mental Health at the Eastern Mediterranean Region Office of the WHO. And he's going to provide a regional perspective on their program. And then finally, we'll have Liz Grant speaking, another professor of global mental health, and she has extensive experience in influencing international agenda. She's worked with the UN. Although based in Scotland, she's got extensive global mental health experience and has worked in various low and middle income countries in Latin America, Africa, and Asia. And she's much more interested in how do you develop health systems in these areas. And I'm really pleased that we'll also have Grace Katera. And Grace is an expert by experience who's based in Rwanda. And Grace, I hope, is going to give us when our speakers have spoken for about 5 minutes each, she's going to give us the service user and the lived experience perspective on what they've said and her thoughts. How does it feel to be the person who is trying to interact with health services and trying to ensure that you get support? So without further ado, I shall ask Ricardo if you could come and speak to us and tell us your thoughts.
Thank you very much. For some reason, I cannot open my video, but it doesn't really matter. You don't need to see me. Thank you so much for inviting me to this very interesting session. I know I only have 5 minutes, so I need to move very quickly on what I think about cross-sectoral collaboration. And I just chose that title, A Long Journey, for the very simple reason that I think that cross-sectoral collaboration, it is yet an aspiration rather than a reality. So far, most of the work in this field, it is within our own sector, the health sector. With the introduction of the SDGs, there has been a fabulous opportunity to kind of reintroduce and give further impetus to the idea of intersectoral collaboration. As you know, SDGs place a big emphasis on the social determinants of mental health. I just put it on the left-hand side so that you can have an idea what we're talking about. But it will take a long time for countries to accept and act on these social determinants. Nonetheless, they provide an opportunity to push on with the intersectoral initiative that might eventually have an impact on mental health. But I wanted to make you aware that some of these actions, I put 3 examples in there: better employment condition, better housing, or even cash transfers, all of them coming from different sectors, are essentially political decisions that have very important economic implication. So they are not taken lightly by those who have to make decisions. So therefore, the challenges are probably quite obvious. In the first place is that the world has been organized in a compartmentalized, that's a very difficult word. It has been organized in a compartmentalized world where, we have at government level departments of education, work, you name it, and so on. Each one of them has its own budget and its own program. And even though there is an effort to try to coordinate activities and introduce intersectoral collaboration, it isn't always easy to do that. Therefore, and especially as a researcher, I can say that the evidence on the intersectoral collaboration, the effectiveness of these, is very limited at present as to what works for mental health and what is the actual impact or effect size. We did have, you asked me if I know some successful one. I'm afraid I couldn't think of. There are a few things, of course, and I think the one that immediately came to my head, it was with the educational sector. There has been a lot of work in schools with mental health programs. I'm for one of those people who did a very large trial several years ago in Chile, the country where I was born. And I must say that it was a negative trial, and I was very honored to recognize that. And therefore, I was declared as not a, it wasn't considered to be something to invest. On the contrary, the Ministry of Education considered this something to disinvest. And I couldn't be against that idea because I didn't have the evidence to support this program. However, not much to my surprise, but I was slightly disappointed. I could see in all those years working with the educational sector in Chile that there were lots of other programs that had no evidence or indirect evidence or very limited evidence that had received massive investments. And that has continued to be the case. So what I want to say with this is that politics is sometimes a lot more important than science. And unless we can convince politicians that intersectoral collaboration is important for mental health, the future still, looks a bit doubtful. Thank you.
Thank you very much, Ricardo. That is a very speedy cut through, and I have to say, absolutely spot on. I'm going to ask now, I'm going to ask Khalid, can you give us your thoughts, please?
Yep. Ricardo, if you could stop sharing, then.
Yeah. And just to remind everybody, please put your questions and in the Q&A whilst we're waiting for.
Is it possible to see my screen?
Yes, we can see it. You just need to make it bigger. Lovely, thank you.
Brilliant, thanks. So thank you very much, first of all, for inviting me. And I mean, I'm sure all of us are aware that fairly recently this World Mental Health Report was launched, which sort of highlighted that mental health problems are common. They are sort of among the leading causes of disabilities worldwide. And at the same time, they are also responsible for premature deaths of people with mental health problems. And given that over the last couple of years, we have been living through the pandemic, and the region I am coming from, where almost half of the countries in the region are experiencing chronic emergencies before that, the mental health problems tend to multiply. I mean, you can see that the rates tend to almost double in individuals who have experienced adversity in the last 1 year. And that has been highlighted during the COVID pandemic when we saw the rates of common mental health problems like anxiety and depression going up quite substantially. And at the same time, the services were disrupted quite badly. Now, coming to the gaps, when we are talking about it, when it comes to intersectoral collaboration and provision of services, for me, I think one of the key problems is the conceptual gap, that mental health is often sort of used interchangeably with mental disorders, rather than keeping in mind that mental health is a core component of health and well-being. And without that, we are not what we are. I mean, it actually defines who we are, how we react, how we function, how we connect and relate to people. So the problem arises that because of this conceptual gap, what happens, which Ricardo, I think, was alluding to, is that when it comes to translating this concept of mental health into concrete policies and plans, that results in this kind of disconnect between the policies we see and the legislative sort of frameworks which are there. And consequently, mental health does not get a mention in the national development plans, which are generally now being looked at in most of the countries in light of the SDG agenda, as well as in the humanitarian plans. I mean, there are mental health response plans are there. But the fact is that they are not mentioned in the national humanitarian plans, preparedness, response, and recovery plans. Same is the case when it comes to the developmental plans, that mental health hardly gets a mention in that. Health might get a mention, but that doesn't really translate. And consequently, what happens is that you see this resource problem, that on an average, most of the countries, particularly low and middle income countries, spend less than 2% of their health budget on mental health. And that is compounded by where that budget is allocated. Mostly it's allocated to the big institutions rather than community-based care or on prevention and promotion programs. Similarly, that also results in this huge literacy gap, because often mental health professionals, advocates, civil society organization, etc., they tend to use these terms interchangeably. And consequently, there is no coherent message when it comes to mental health. And that contributes to the rampant stigma, discrimination, and human rights violations all of us are aware of, particularly in low and middle income countries. And subsequently, we are also seeing problems at the programmatic and implementation level, which translates itself into this huge service gap, which we are seeing, with limited focus on prevention and promotion, as well as when it comes to the translational research in particular, and the fact that mental health hardly is integrated into the national health information system in majority of the countries, particularly low and middle income where I work. Now, what do we need
to do? So
Khalid,
you've got about 35 seconds.
Yeah, so what do we need to do? Basically, I think there are three things, or four things rather, we can do. First is that we need to articulate mental health as an integral component to development and peace. Secondly, advocate for resourced integrated mental health services across population, community, healthcare platforms, and delivery channels. Empower and meaningfully engage people with lived experiences and promote research, information, and evidence, particularly locally sourced. Now, and we have a wealth of resources available to draw upon, and the time is that we should start moving forward on this. Thank you, and over to you.
Thank you very much indeed for that speedy overview of what we need to do. So without further ado, I shall now hand over to our final speaker, and who is Liz Grant. And Liz, a very, very, very warm welcome. I know that it's not been straightforward for you getting in, so thank you very much for being with us.
Thank you so much, and for all your help as well. And you know, the last two speakers, you really hit the mark, didn't you? Talking about the power of politics to bring about change and the challenge that we have because mental health isn't described and curated and collated in the way that we need. And there's so much that this festival can do to really bring about change. I just want to speak for a few moments without slides, because I want to talk about two things that's really been hit on already this morning. In the Human Development Report for 21-22, we live in an uncertain time, we live in a world of worry. That's what the report says: uncertain times, unsettled lives, shaping our future in a transforming world. And that the report lays out the crisis we're in, but it also points to some places and areas where we can work together. And I think this is so critical. It lays out the crisis because the crisis we're in at the minute that really is challenging the whole of mental health is a divided world, a fragmented world, a world where there is a lack of trust. And the question to all of us, and it's going to come up over the course of this week, how do we build back trust in a way that changes and allows the ability of all of us to contribute into something that is so fundamental? You know, the WHO report has already been referenced, and Dr. Tedros said in that report that mental health is such an intrinsic part of our individual and collective health and well-being. We need to transform our attitudes, our actions, our approaches to promote and protect mental health and provide care for those in need. And what I'm going to suggest is that we look at places where we can bring about change. And the places that we can bring about change are identifying the silos that we work in. Because where there's uncertainty, where there's fear, where there's distrust, there are barriers, there are walls put up, there's separations, there's an us and them starts that becomes huger and huger and people draw back. 4 areas which are critical as we think about this. And the first area is about the boundaries that we set between our professional and our personal and our private. And we're increasingly seeing people seeing almost an inauthenticity between these lives. How can we change that? The boundaries and the borders that we are setting between the way that we value society and the values that are in society. There's a disconnect. The boundaries and the borders and the separations between the way that we treat nature, the way we think of nature as somehow the great outdoors, when nature is inside of us, when we need to be connected, and the boundaries between mental health and physical health, between those who are ill and those who are not. So what do we do with the fact that we have got series of separations, with barriers, with boundaries? What is it that can change the space between, that can fill the space between, that can begin to move from the very black and white, the set aside and set apart, to draw together? I'm going to suggest compassion. And the reason I'm going to suggest compassion is that compassion isn't something light and fluffy. It's not something that you somehow do as an extra, as an add-on. Compassion is so fundamental to human nature. I mean, it actually is the thing that keeps us alive, caring for each other, believing in each other, trusting in each other. And I want to use a definition of compassion that's been developed by a really great colleague, Monica Warline. And she says that compassion can be thought of in 4 parts. Compassion is about noticing pain and suffering. And I want us to think throughout this week and think, do we notice pain and suffering? Really notice? Not just rush by, but notice. Compassion is also about interpreting the suffering. Why is there suffering? Why under each of the Sustainable Development Goals is there an abyss of suffering? Why in health is there underpinning our health goal and our health goals and responses? Actually, we're talking about trying to alleviate suffering. Compassion is about feeling empathetic concern, leaning into, engaging with, and most importantly, compassion is also about taking action. So these four things, noticing, interpreting, feeling, and taking action to alleviate suffering, constitute what I see as compassion. And the reason that I want us to think about compassion in this context is because it helps us understand that we are whole together, that we are a community, that we're born equal, our essence is equal, though we are born into very unequal circumstances. We are a shared humanity. That's what compassion tells us. It also tells us and enables us and gives us the capability to care for each other, the capability to listen, the capability to begin to build up the components that we need to have trust, to trust in each other, to trust in the organizations, to call out organizations and ask for support, but ask organizations, agencies, institutes, politics to be responsive to what we need.
Thank you very much indeed, Liz. Thank you so much. That was incredible. All right, so now noticing pain and suffering and interpreting suffering and feeling. That's is Liz's call to all of us, actually, in particular to all organizations. I'm going to ask Grace if you could join us, and I'd ask all of our panelists, please, if you could perhaps put on your video so that we can see you. I'm going to ask Grace for your thoughts. Actually, no, Grace is an expert by experience, and she's based in Rwanda. And I wonder if, Ricardo, if you are able to put your video on, great. If you're not, you'll let us know.
No, I can't do it.
Okay.
Somehow you block me. Okay. I can understand. That's okay.
We can hear you. We can hear you. Okay. Anyway, and Grace, I wonder if you just to let everybody know, actually, we're going to have a slightly shorter panel discussion because of our technical difficulties starting. So it will be it will be about 12 minutes or so. And Grace, I know that you can't, your camera isn't working, but you can hear us, and I'm hoping when you speak we'll be able to hear you. So I wonder if you could let us know what your thoughts were from what you've heard. And if you had any questions for our panel. Yes, we can hear you. Lovely. Welcome, Grace. Welcome. And if you have any questions for our panelists, but tell us your thoughts first and then any questions you might have.
Right. It's been incredible listening to my colleagues speak. I took down a lot of notes about the first thing Ricardo said about aspiration instead of a reality. I fully agree with. And, you know, Khalid building on that, talking about politics, and then Lee coming in with, you know, something that is really important that I think we don't involve in mental health a lot, which is about compassion and understanding and interpreting pain. As a Black person, that resonated with me a lot. So those are my thoughts. And yeah, about what we've all said, I sort of agree, but would like to push back on what we usually say, meaningfully involving this experience. I think that in order for this to go from, you know, an aspiration to a reality, we have to sort of shift the way we think. So sorry, you can't hear me? Can you hear me still?
Yes, we can still hear you. We can still hear you. It's a bit fuzzy, but we can hear you.
Okay, I'll try to be as loud as possible. Yeah, I was 4 years ago when I started speaking, someone asked me what lived experience can bring to the table. And I said, you know, throw the whole table away. But in the 4 years of working that I've done, I've come to realize that there is no table, that whatever is there was brought in by people. and it can always be deconstructed. Therefore, lived experience has to take an equal footing within this mental health, framework, so that if change has to be made, then lived experience has to contribute equally. And that's going away from using wording like involve to how can we bring our peers across the field? That's cross-sectional collaboration. How can we bring in lived experience experts to sit in the expertise that exists already within mental health? And one thing that Liz talked about was shared humanity. And me, I would like to add on that. We need to have shared humanity, but also optimism, because nothing can be done when we're not looking towards a better future. So if we can, cultivate that and maybe create optimism in our work, I think that would change everything. I sort of have a broad question about to Lee, and the question would be, how can you convince someone of humanity, especially in technical mental health work?
Okay, so that's quite a challenge. Thank you very much indeed, Grace. You spoke about this is an aspiration, as Ricardo said, but it needs to become a reality. That's got to be something to do with the people in the room, and we've got to make sure that it's not simply involving people, consulting people who've lived that experience, but it is ensuring that people who've lived that experience are at the heart of everything, and that they are part and parcel of the solution. Okay, so the question you've asked is, how can you convince someone to bring in, the organizations, etc., to bring in the humanity, the compassion? I think I'll go to Liz first. And also just remind everyone, put your questions, not in the chat, but in the Q&A. Liz.
Thanks, and not an easy question at all, Grace. And I think you've got so many of the answers to it, though, as you talked, because it is this shared humanity that each of us know. My response, and the response I have with organizations I work with, is to think about how organizations actually engage with each other. What provides the greatest, if I can use that term, productivity in an organization? What allows the greatest openness in an organization to flourish? And as we talk to leaders, they'll often say it's the relationships between each other that really sparks innovation. It sparks a good working environment, a sense of care, and that in itself nurtures and appears to deliver better than an organization where, bluntly, there is no compassion or where there's no care. And all leaders can describe an organization where there is no care, and they don't want it. They see it as something quite frightening. But that's one small way. The other is just picking up what I started with, the human development reports really pushing out at the minute, the distrust, the dysfunctionality, the increasing rise of anxiety. When we recognize that, we begin to see there is something wrong with our functions at present. But I'm conscious Ricardo and Khalid have also got contributions, and Larry, you yourself have got great insights in this.
So actually, Ricardo, Khalid, Ricardo first, any thoughts that you might have about Grace's question?
Yeah. Well, my first thought, thank you, Grace. I mean, it's, thinking about how to be humane in these days. It's just something that it's at the top order, I mean, when you think about that people are getting very low wages, they cannot even pay for their food. People in some part of the world didn't even have access to vaccines during the COVID. Massive inequalities, no respect for the rights of workers. I can give you such a big list, of the world in which we live. I mean, to be humane, to be human, perhaps to be human these days, it's a major challenge, it's a major challenge. We are really going against a society that is not making it easy. So what can I say? You know, a lot of this intersectoriality, it is affected by this, you know, because it involves things like that, you know, which, you know, how do we give a fair wage to people so that they can have their basic needs covered? I mean, let's start there, shouldn't we?
Yeah, very good point. Khalid, what are your thoughts?
Well, I think, you see, when we try to conceptualize mental health, for me, I mean, essentially what defines you as a human is your mental health. I mean, how you think, how you perceive, how you feel, how you act, how you relate, all these are functions of your mental health. So having good mental health or focusing on promoting mental health, my feeling is that people with good mental health should be able to display and act compassionately towards people who are less fortunate.
Mm.
So that brings us to the main thing, that how can we promote mental health? And that's what I think Ricardo has been mentioning in his presentation and in his talk, that promotion of mental health obviously is not the job of health professionals per se, or it's not limited to that. So until unless we bring in this opportunity which we have through the SDG agenda and the humanitarian agendas, both of which keep on saying no one left behind.
Yeah.
So what do you mean by no one left behind? I mean, how do you translate that into a reality? And
Okay.
that, for me, if we want to move forward, we need to pitch mental health as the glue, which brings all these agendas together. Without that, it's not going to happen.
Okay, so
whether we are talking about SDG 3,
Yeah.
health-related SDGs or education-related SDGs or poverty or food security-related SDGs or developmental-related other SDGs, mental health is the key substrate which we need
Yeah.
to put into place to move forward.
I love that term. Actually, mental health is a key substrate that we need. I'm going to actually challenge something that's been said, which is that we know that compassion is absolutely crucial, but the reality is that, as you've all pointed out, and Ricardo very clearly pointed out, that even though we know compassion is needed, we're living in a world that doesn't feel very compassionate at the moment. And I'd say, well, given that situation, maybe we need to think about it in terms of the economics. We know that actually mental disorder arises in youth. That stops people from being able to achieve their potential. They're less able to contribute to the economy and so on. Actually, failing to attend to mental health is actually an economic issue. Michael Marmot has shown that very nicely. I wonder what your thoughts are about maybe some practical ways that we can encourage our governments and our policymakers to attend to mental health and the compassion using perhaps an economic argument. Who wants to go first? A nice, easy challenge.
Yeah, well, I'll go first. I mean, I personally sometimes find it, I will be honest, I sometimes find it a bit irritating that people overdo the economic argument. Mental health is a right. It's a basic human right. People who have, to have that, as Khalid said, to allow you to live a fulfilling life to begin with. And if you happen to have a mental disorder, to be treated and helped so that you can come back to society and make your contribution. But to say that, the economic argument sometimes, yeah, there may be things in there, but it hasn't cut any matter so far. We've been repeating this thing for years and years, for decades, the loss in, productivity, how good an investment it is, the return of investment and this and that. But politicians are not buying it. So that's my reaction to it.
Okay. Khalid, what are your thoughts? Oh, you're on mute, sorry.
I tend to agree with Ricardo. I mean, I think there is a reasonable amount of evidence in terms of, making an case for investing in mental health. Lost productivity, gains, return on investment, all those arguments are there. And as far as I can see, that there are initiatives at this point going on for developing country-based investment cases for mental health. And some of the sort of countries, particularly low and middle income countries, have already developed that. And if we look at what was done for NCDs, you would see that investment cases per se don't move the agenda forward. It's a tool, yes, but it should be taken as a tool and nothing more than that. It should not. It's not a panacea for suddenly somebody would look at the investment case and start pouring money into mental health. No, I think we need to have a multi-pronged approach here.
Okay.
One prong of that is obviously human rights.
Okay.
That is one prong. But at the same time, I think we need to push forward on the fact that mental health would be key when it comes to peace and development. Because, I mean, when we say that mental health is important for relationships, if you look at the wars and, civil unrest, which is going around the world at this point, I mean, hardly any country is immune to it. And I think Liz was mentioning about the distrust thing. What is that? That is primarily because this breakdown in being able to communicate and relate.
Okay.
So we need to make that argument as well, that it has this advantage. And there is some evidence now coming through that mental health could be the bridge towards peace. And same is the case when it comes to development. That if we want to move forward as a country or as a community of nations, how would you move forward without having mental health as the key sort of building block there? So I think we need to make an argument which is multi sort of pronged rather than just moving forward on one.
Okay.
Sort of
so we have just a few seconds left, and we have a question. It's a really important question. I'm going to ask Liz. So one of our attendees has said, yes, I agree that compassion should be a core characteristic that we as humans should strive for. But what are the effects of too much uncritical compassion? If you could answer that one, Nobel Prize for you.
Really important, actually, and that's where I try to segregate compassion into these four components, because compassion is wise. It's about a real recognition, not just of being empathetic and feeling sorry and feeling sad and creating almost a burnout, but actually being able to work together with people to bring about change. And that's key for compassion, bringing about change that's focused in the belief that we are equal together, that we matter to each other. The com part of compassion, the together with suffering, it's the together part often is forgotten. But also, can I just say one thing as well? As we think about mental health, it's the mental health of people. And in the end of the day, the people and the planet we live in, these are the two things we have. People on our planet together. And if we don't invest in people, the greatest asset of the world, then where do we go in all our systems? So it's not about investing in one thing, it's investing in people and ensuring that people's mental health and people's physical health, which is whole, comes together. It's so important. I think what Khalid and Ricardo have said is it's more than an economic argument.
Okay, well, thank you. Thank you so much. So on that note, we will have to finish, unfortunately. If only we had another hour, because there's lots and lots of stuff coming in through the chat now as well. I'd just like to say thank you very much indeed to Grace Katira from Rwanda, to Liz Grant from Scotland, from Khalid Saeed, to Ricardo Araya. Thank you so much for your insights and your thoughts and your time. And thank you, all of you. Please continue to contribute. And now over to Helen. Thank you.
Massive thanks, Lade, and all the panelists. That was a really fantastic session. Loads of really inspirational talks and amazing discussion on the importance of cross-sectoral collaborations for improving mental health. We've certainly highlighted quite a lot of the challenges that we face, which are not insurmountable, but also some really great suggestions for how we can improve the effectiveness of these collaborations. So thank you, really, really appreciate it. So as Lado said, we'll now move on to the second session of today, and we'll continue with the topic of cross-sectoral collaboration in mental health. But we're going to move to some examples of collaboration with industry. And it's another real pleasure to introduce Anne John, who's going to chair this second session. So Anne is a professor of public health and psychiatry at Swansea University and a consultant in public health in Wales. She's also the principal investigator and co-director of DataMind, which is a health data research hub for mental health. And a real honour to have you with us, Anne, and I'll now pass it over to you to chair our second session. Thanks so much for joining us.
Thanks so much, Helen. I'd just like to say how grateful I am to be here to chair this session, because, you know, the previous sessions really highlighted, you know, cross-sectoral working across disciplines, but also with policymakers. But one of the sort of cross-sectoral partnership working we often don't talk about is that with industry, because there can be some tensions in our field. So I'm really grateful for the following three speakers who I'll introduce just before their talks, and then we'll have time for a panel question and answer session where Jan Speechley, who's one of the patient and public members of DataMind's what we call our super group, will be joining us as well. So first, it's my pleasure to introduce Hussaini Manji, who's a visiting professor at Duke University and honorary fellow at Oxford University. He was previously global therapeutic head for neuroscience at Janssen R&D, Johnson & Johnson pharmaceutical company. And he's received a number of prestigious awards for his research in this area. And I think this will be a really interesting insight into where that cross-sectoral working can benefit patients, the public, and researchers in terms of improving mental health. So over to you, Hussaini.
Thank you very much, Anne. Thank you to Parisa, to Lee, and the meeting organizers. It's a real pleasure to be part of this very, very important discussion. I'll try and share my screen and see if this works. So I think, as we all know, we've heard in this previous session that mental ill health and mental illness is one of the greatest challenges of our time. Certainly people have referred to it, and I don't disagree, as a civil rights issue of our time.
Hussaini, we can
Yes.
see that you're almost screen sharing, but we can't see your slides yet. Sorry.
Okay, let me try again.
Perfect.
Do you see them now?
Yes.
Great, sorry, and apologies for those technical difficulties. As I was saying, we certainly know there's a lot of challenges in this space, and the previous panel really outlined them. Hopefully, I'm going to give you a little bit of a message of hope and optimism that we are starting to make a difference, and that's by working together. I think it's fair to say that we all know that mental illness and mental ill health has really caused a devastating impact on society. We'd like to have been further along in terms of treatments, whether they're psychological, social, or medication. Why is it that we're not further along? And I think this slide tries to capture some of those things, that we are dealing with fairly complex conditions. Certainly at the bottom left, you inherit a lot of these, genes that put you at risk, that, brings about this cascade, ultimately affecting these brain circuits that are responsible for things like depressed mood, inability to feel pleasure, motivation, drive. We know there's a host of environmental factors that interact with the genes and the biology that you heard in the previous talk. I think that's one of the areas where we're starting to see some optimism, that what we're starting to see is, rather than trying to treat all of major depressive disorder, or all of bipolar disorder, or all of schizophrenia, we're breaking down these conditions into component parts and then trying to target the circuitry of those component component parts. For example, anhedonia, the inability to experience pleasure. If we can treat anhedonia really well, then we can treat the anhedonia, whether it's depression, whether it's bipolar disorder, whether it's schizophrenia, and so on. So I think that's one of the things that's going to help us. There have been a lot of advances in the biological sciences, and that's depicted on the left. Just to give you two examples, on the left, if you see what's circled with the blue circle, that refers to certain molecules that we sometimes call plasticity molecules, which seem to be very important for regulating brain function, and in fact have been the basis for developing rapid-acting antidepressants, something that was thought of as being unheard of some decades ago. Now we can treat severe depression in hours rather than weeks, and obviously we want to build upon that. Staying on the left-hand side, if you look at the red circles, that's been another area that is starting to explain why so many people with mental illnesses also have so many what we call physical comorbidities, so cardiovascular disease, type 2 diabetes, obesity, because we think that the immune system is also involved. And there's a lot of research now going on in those people who have both mental illness symptoms and physical illness. Could you really target the immune system to bring about benefit in both? And then if we turn to the right-hand side, I think the other advance that's really happened is in digital technologies. And one of the reasons I think this is going to be very important, and of course we need to be very cognizant of things like privacy and data ownership, is that we know that unfortunately most people with depression, bipolar, schizophrenia, etc., have multiple recurrences and relapses. And what we tend to do right now is almost wait till they relapse. Wouldn't it be better if you could get early warning signals that they might be on their way to relapse? For example, if sleep is changing, activity is changing, speech is turning out to be very important. So if you could get early warning signals and help people before they reach a crisis stage. Similarly, we know that there's many types of psychological interventions, and cognitive behavioral therapy may be a good example that certainly work and work well, but we don't have enough people to deliver them one-to-one. So could we deliver them in a sort of digital way? And I think that's one of the things that's going to allow us to reach a lot of people. I think one of the reasons, as I said, to be optimistic is not only in the science, but in what I call the culture of science. And I think the HIV/AIDS community is a great example of this. Not only have they really been able to reduce stigma, but they got everyone to work together. So they got governments to work with patient groups, with industry, with legislatures, etc., to insist we need better treatments, we need help for our loved ones. And as I said, I think it's one of those success stories where we've seen a dramatic improvement in the outcomes. And I think that's what we need in this space. And I think we're certainly starting to see that. So this is just one example. And there's no doubt I'm showing this slide partly because it shows me with Justin Trudeau and Michelle Obama. But I think the fact that I'm with the two of them shows you that governments are starting to take mental ill health and mental illness quite seriously. And I'm pleased to say that the UK government has actually made mental health and mental illness one of its priority missions in their new life sciences vision that has brought together a lot of stakeholders and people from the Office of Life Sciences like Heather Hobson, from the NIHR like Louise Wood, from the National Health Service, David Pryor, Tim Ferriss and others have been working with many stakeholders to basically see how can we work together to really make a difference in mental illness and mental ill health. This mission should have been launched some months ago, but due to what you're obviously aware of, some of the turnover in the government leadership, it's been delayed a bit, but the hope is that before the end of the year, this will get launched. What is this? So this is going to be setting up what we call translational centers of excellence at some of the key universities. And when I say key universities, some of those will be some of the bigger name universities, for example, like Oxford and King's, but some of them will also be where a lot of the patients are, and a lot of the people who might have some socioeconomic disadvantages or different racial and ethnic minorities. So places like the Midlands with Birmingham, places like the North with Merseycare. And the hope is that working together, we can start to get beyond this one-size-fits-all approach. So to start to understand what are the patient subtypes who may benefit from a specific treatment.
Hi, Husseini. We've only got a minute left, sorry.
Okay, so I'm about to end. So we will set up these networks. These networks will be connected to the National Health Service, so we can not only develop better treatments, but deliver them to people. And I'm delighted that this initiative has the lived experience as part of it and Lee Milligan's part of it. So just to conclude, I think we know we have a lot of challenges. I think we are making progress. I think we need to work together, which is the focus of all this discussion today. And I think we need to start to move to what I call preemption. So can you help people before they have serious illness or multiple recurrences? So I'll stop here and be happy to take any questions in the question and answer, and I'll stop sharing. Thank you.
Thanks so much for that. I'm going to move us quickly on to our next speaker so that we've got as much time as possible for questions at the end. So we're going to hear from Louise Marshall, who's who used to work at Wellcome, leading on a sort of £5 million portfolio of research into brain and behaviour. But she's now the Director of Mental Health Sciences at ISO. And she's a neuroscientist by training, and she's developing a human-centered research programme that raises standards for effective and scalable mental health care. So over to you, Louise. Thank you.
Thank you very much, Anne. It's a real pleasure to be here. Hopefully you can see my slides okay. And today I'm going to be talking about how ISO is learning from 100,000 journeys through our care service to transform mental health science. So I don't need to tell this audience that mental health problems are a huge challenge. The numbers really do speak for themselves, and sadly, it's unlikely that any family is left untouched by them. But mental health care has an access problem. Demand for treatment far exceeds supply, and there's also a quality problem. So even when people are able to access treatments such as psychological therapies, they work roughly 50% of the time, and we can't reliably predict which treatments are most likely to be effective for particular individuals. So who are we, and how are we trying to tackle this challenge? Well, ISO is one of the largest providers of psychological therapy services to the NHS in England and Scotland. We deliver NICE approved therapies for common mental health conditions such as depression and anxiety in adults using a digital text-based interface where a therapist and a patient have a one-to-one typed conversation over a series of treatment sessions. Importantly, this method of delivery has been shown to improve treatment access and to effectively reduce mental health symptoms. To date, we've delivered over 500,000 hours of therapy to more than 108,000 people. And just like NHS IAPT, which is a world-leading national mental health service, we monitor patients' depression, anxiety, and other functional measures before, during, and after a course of treatment, so that we can learn across the system by capturing whether the therapy we deliver leads to meaningful recovery for our patients. We also go one step further than IAPT. Because our therapy is text-based, we're able to capture every exchange between a therapist and a patient. And this means that we have a globally unique data set of de-identified outcomes indexed therapy transcripts that's enabling us to learn for the first time which specific elements of psychological therapy are working for whom at scale, and feed these insights back to refine the treatment we deliver so that we can improve its effectiveness. So how do we do this? To unlock the insights held in our treatment data set, we've developed an AI-based tool that uses a deep learning model to understand the therapeutic intent of the language in the transcripts and automatically annotate every element of therapy delivered. So as you can hopefully see in the video that's playing, the tool assigns categories such as greetings, mood checks, session planning, homework reviews, and change methods. And by monitoring session by session outcomes, analyzing how they relate to elements of therapy that are delivered, and feeding back to therapists which elements are effective, we're able to improve the quality of the care we provide. But as Husseini says, we know that a one-size-fits-all approach is not enough to meet individual needs. And we're now focusing on personalizing psychological therapy by learning how best to target a person's specific symptoms with the most effective elements of treatment. So we know that depression and anxiety are highly heterogeneous conditions. Different people experience different symptoms, and these symptoms are driven by a very complex interplay of biological, psychological, and social factors. And historically, the field has lacked a principled way to really stratify individuals who fall within very broad diagnostic categories. But we found evidence in our data set that different symptoms of depression are associated with different depression subtypes, and that these subtypes show different responses to psychological therapy. By understanding how different people with different symptoms respond to specific elements of therapy, we'll be able to treat people faster and more effectively by accurately predicting which elements are most likely to work for a particular person first time. But we cannot do this alone. Real-world data is highly complex, and even though formulating the problem may be relatively straightforward, finding the solutions is not. And the really big opportunity here is to work across sectors by using insights from our large-scale real-world treatment data set about what is working for whom to inspire new fundamental research questions about the biological, psychological, and social mechanisms that contribute to mental health conditions and drive treatment response. This effort will require a multidisciplinary mental health science approach and should be informed by expertise by experience to help ensure we identify research questions that are most likely to lead to meaningful benefits for people living with mental health conditions. With the research and knowledge that this work generates, we believe it will be possible to take a smarter approach to treatment by refining existing treatments so that they're more precise in targeting the mechanisms that cause depression and anxiety, by inspiring new treatments that target these mechanisms, and by understanding how to intelligently combine different treatments such as psychological therapy, drug treatments, or social interventions to improve and maintain recovery so that millions more people have access to high quality, effective mental health care. Thank you.
Thanks so much, Louise. That was perfectly timed. We'll come back to questions. So I'm very pleased to introduce our final speaker for this session, Professor Alan Young, who's Chair of Mood Disorders and Director of the Centre for Affective Disorders at King's College London, where he's also Head of School and Vice Dean for Academic Psychiatry. So I'm going to pass straight over to you, Alan. Thank you.
Thanks very much, Anne, and thanks for the invitation. It's very nice to join you all today. I'll crack on because time's obviously limited. My title comes from Miranda in The Tempest, but you'll all, of course, know that it was used by Aldous Huxley to talk about dystopian future possibility. So I think those things are worthwhile bearing, that can either be a good future, a bad future, or a mixture of both. These are my disclosures, which I won't dwell on. We've heard much from others today about the fact that common mental disorders ranging from childhood to adulthood are a big healthcare burden, and we heard very informed discussion about that. So I won't again dwell on that too much, apart from to say the fact is that COVID's made everything worse, not least because of the problems it has imposed on mental health services in every country. There are numerous clinical trial challenges for new mental health treatments. These are listed here. Reliability and validity of diagnoses are variable. Comorbidities, including, as Husseini said, physical health comorbidities are common. We have specific methodological issues with discerning whether the placebo effect is actually driving the apparent results or not. And this applies to psychotherapy as well as drug effects. We need to think about long-term effects of medication and indeed every other treatment, including neurostimulation and psychological treatment. And of course, there's multiple subtypes of disorders. We're stuck somewhere about 100 years ago in terms of our classification compared to the rest of medicine, which has moved on with defining in a much more granular way the problems that they deal with, whereas we're still dealing with concepts first formulated in the 19th century. So probably the best way to think about addressing this is the combination of industry, the government and academia. And this is exemplified by academic health science centres. This is our one in King's Health Partners. Big turnover, tens of thousands of staff, many patient contacts. And this gives the scale for really trying to have large-scale collaborations with industry, with partners in Europe, and with people in the rest of the country. And here's the conceptual framework, which I think is very helpful for us. This really goes from experimental animal models right through to digital applications, looking at neuroimaging, neurophysiology, biomarkers, digital, which I think is a great hope for the future. Others have spoken about this. Open science, which is, I think, essentially a very good way of keeping us honest, and clinical communication. And this cuts across risk factors, pathomechanism, and early detection, prevention, and intervention. This is actually from our trans-campus collaboration with Dresden, and we have a joined-up collaboration with Germany, which is the basis of many European collaborations, which again, I think are very much a good thing for trying to produce results. And again, we've heard lots about this from others, but it's about digging down into the risks and pathomechanisms, both biological, psychological, and social, looking at what results in adult human disorder, affective disorder here, but thinking also about trying to intervene as early in the potential trajectory of development of illness as possible. And one concrete example from our own institution, this is cannabidiol. This goes from discovery science with antipsychotic effects in animal models, and through to experimental medicine, where we looked and saw that cannabidiol blocks the induction of psychosis by THC and had the opposing effects to THC on brain function, and following through to phase 2 trials, which showed that CBD improves psychotic symptoms in patients with psychosis. And now there's the possibility of large phase 3 studies, which might bring one of the first truly novel treatments for psychosis in a generation. I'll stop there. Thank you for your attention, and be happy to join in to the question and answer. Thank you very much.
Thanks so much, Alan. That was perfectly timed.
Good.
Could all the panelists unmute themselves and put their cameras on? So Jan, I can't see you at the moment. Ah, there you are. I don't know, before we take questions, Jan, you're a member of Datamine's super advisory group, where we're particularly focused on developing industry standards for partnership. So I just wondered if you wanted to say a few words before we launch into questions.
I did want to say a few words, and I've also got a question which is directly related to industry, if that's okay.
That's fine.
Thanks very much for the very inspirational talks. I just wanted to say that cross collaboration with industry, academia, and the health sector, with lived experience and the public, can only lead us on an amazing journey with much bigger societal impact and more understanding of research and data by everyone. I hope we can all work together to improve mental health. And I hope very much from a lived experience perspective that the more knowledge we get, the more influence we will have on that research. My question to the panel is, can industry, the health sector, and academia share lived experience partners in a trusted environment?
Okay, I'm going to go to Hussaini first because he indicated.
Yeah, thank you for the question, Jane. And I think absolutely. So I do think that increasingly there is a recognition that, if you're trying to help people with lived experience, they got to be at the table. So they got to be at the table in many ways. Alan was describing those elegant studies, etc. Sometimes as scientists, we think this will be the great study, but then what we tend to do is bring people with lived experience to guide us. What's going to be the patient burden? You're really focusing on this outcome where it's this thing that really affects me or my loved one. And then I think so we have people at the research design standpoint But then even beyond, when you want to, hopefully sort of move forward, whether it's digital or medication or other interventions, have people with lived experience at the table guiding you. What's the best way to do this? What's the best way to ensure privacy? What's the best way to, as Alan said, have open signs so that the work is shareable, etc. So I think, as I mentioned briefly, in this UK mental health mission, lived experience is going to be a critical part of it. My anticipation is that there'll actually be a lived experience council that will work hand in hand with the academics and the industry folks to make sure that the voice is fully represented. It's not just a token, check the box. Thank you.
Thank you.
Thanks, Hussaini. Is there anything, Louise or Alan?
Yeah.
Yes.
Yeah.
You go, Alan.
Oh,
No,
Alan
Louise,
and then Louise.
Louise, do go first.
Okay, thanks. Yeah, I would completely echo what Hussaini just said. And at IESO, we're really passionate about growing our involvement of expertise by experience, and this really recognizing this as an absolutely fundamental principle that needs to underpin a really responsible approach to innovation and industry innovation in particular. And I think it's important for two main reasons. One, I sort of mentioned in the talk, the huge potential to be able to work backwards from what is working to sort of inspire new scientific research questions about the mechanisms that are underpinning treatment response in mental health conditions. And to me, the expert by experience voice is absolutely critical for improving the focus by making sure that we're focusing on mechanisms and scientific questions that are most likely to result in improvements and change that are actually meaningful for people experiencing mental health conditions. So very similar to the point that Hussaini was making. The other key point I think that is absolutely critical is really embracing and properly considering trust. So you often hear a lot about how can we build trust with expert by experience communities, but I think there's also a really important point here about how can we demonstrate that we as industry are trustworthy, and really meaningfully understanding the priorities and needs and values of the expert by experience community, and making sure that they are represented in not only the insights that we're gathering from our research, but also how we conduct our research and how we communicate what we're doing. It's absolutely critical to sort of be working closely with the expert by experience community to ensure that we're doing that well. The only challenge that I see in terms of sharing insights across healthcare, academia and industry settings is making sure that we're hearing from a diversity of voices. And I think one of the challenges at the moment is not drawing on the same small groups or pockets, and sort of how can we really make sure that we're learning from a diversity of experiences in terms of the breadth of people who experience mental health conditions.
No, that's really interesting. One of the things we're doing on the DataMind Research Advisory Group is working to try and start the process of developing guidelines for industry and data sharing. And that's an amazing experience, an amazing journey.
Awesome.
Alan.
Yeah, thanks very much. And I, of course, agree with both Louise and Hussaini. I would go further and say that I think one of the biggest advances in mental health this century has actually been the appropriate involvement of people with lived experience, not only in research, but also in delivery of services. I think that can't be overestimated. And the other thing is just echoing what Louise was saying about a diversity of voices. There isn't a one size fits all for feedback about adult mental health. And a good example is the difference between, say, bipolar disorder and schizophrenia. Many of our services in the UK seem to be designed for schizophrenia. Bipolar disorder in many ways is similar, but the Bipolar Commission, which is going to report at the beginning of November in Parliament, actually highlights that the lived experience of people with bipolar disorder is very different from, say, the lived experience of people with schizophrenia. Their priorities are different, and so on and so forth. So we need to capture that. But really having people with lived experience and their families as partners in this endeavour adds greatly to our strength, I think.
Absolutely. I think talking about diversity and representation, I think in physical health trials, we know that representation of underserved groups, even across gender, is not great. And I think when you combine that with trials in mental health, where those issues are heightened, we really do have to think carefully about having both that diversity of voices, but also diversity of participation. And, you know, and I really think that needs to be a focus of what we do. We've had a question from the audience from Karishma Jivraj. I hope I pronounced that right. So what they've said is that the discussion of integration of government, industry and academia, and they've said, let's not forget the public should be factored in here too, is interesting. But how do we align goals where there are different priorities and outcomes being sought in each? Who wants to have?
And I don't mind. Sure, I don't mind going first. So I think it's a very relevant question, and that's one of the biggest challenges, if you will, to sort of align goals. Clearly, the overall goal to improve outcomes is shared by everyone, but there are some, distinct goals. So I've had the pleasure more in the US and some of the European countries to be part of many of these groups where, one is IMI, Innovative Medicines Initiative, another one is the Foundation for the NIH, where you bring different stakeholders together and basically hash out what are the shared goals. So one example that, both Louise and Alan alluded to, is this, the one-size-fits-all approach can't work. We all need to be able to identify who the right person is for the right treatment at the right time. So patients would benefit from that. Industry can target its interventions to that subgroup. Government, funders, etc., can fund these ideal sorts of situations. So that's one example. Another example, and Alan briefly touched on, is once you have something that really does look like it's an appropriate, we call it target, then the race can start. Johnson & Johnson can try and develop its drug, Merck can try and develop its drug, etc. But before that, there's a lot of what we call translational research that need not be proprietary. So can we work together and do the brain imaging or do the digital or do the psychosocial risk factors and, the diversity that Anne was alluding to, so we can understand at a fundamental level, what do we really need to factor in for the ultimate treatments? And that can be a shared societal resource. Then different people can use that. The Wellcome Trust can use it to fund it. Companies can use it to fund it, etc. So I think your question is spot on, but I think there's so many unmet needs, many of which are shared. And these collaborations can focus on those shared aspects and then take on separately their specific goals.
Thanks, Husseini. Does anyone have anything to add?
Yeah, well, very briefly, because I'm aware we're running out of time. Yeah, I totally agree with Husseini, and I think one of the key things is respect for the other stakeholders, having a transparent and inclusive process. And, there's lots of areas that are emerging therapeutically. We're doing lots of work in psychedelics at the moment, in lots of trials, and this is incredibly exciting. But the psychedelic community, if I can use such a phrase, as people who've been using psychedelics over the years have a number of very strongly held beliefs about psychedelics, which may not actually, which certainly aren't based on experimental findings, and may or may not be true, but they're important for us to sort of examine. So I think we need to respect each other, work together, do it in a transparent way. And, I really enjoy working with industry because they're very focused on making things happen. And, that's really a nice thing. They're not perfect, of course, no one is, but they're really good partners to have.
Completely agree. Anything to add, Louise?
Yeah, just really briefly, I think, as Husseini said, the common goal is improving outcomes for more people. And actually, I think the fact that these different stakeholder groups maybe have slightly different approaches or slightly different focuses is actually a strength if brought together in the right way. So again, if we think about the traditional sort of discovery-led approach to academic science, where, we ask very curiosity-driven questions and we're able to translate some of those into improvements in treatment, that's fantastic. And I kind of see in complement an opportunity to work backwards from real-world insights about how people are really responding to treatments in the real world to, focus and inspire new fundamental discovery questions that might be sort of more translation ready back into sort of refinement and treatment. So it really sort of highlights the strength of sort of tackling the problem from two angles and coming together to maximize the potential, so that hopefully collectively we achieve better outcomes more quickly for more people.
So Jan, I can see we've run out of time because Helen switched her camera on. But Jan, I don't know if you've got anything to add.
I think just that it has to work. It has to work. We have to make these collaborations with industry. And from what I've heard today, it does fill me with a lot of hope that is going to happen. So thanks very much.
That's a wonderful positive note. Thank you. So I'd like to thank all the speakers and Jan. That was a really interesting panel discussion because there's lots to tease out in this area. I think we could have kept on talking for an hour. So thank you all. Hand over to Helen.
Pleasure.
Thank you.
Absolutely huge thanks from me to Anne for chairing and all the panelists for that really wonderful session. Really incredibly helpful to hear about those examples of successful collaborations with industry and how much as a field mental health needs to be integrated more with industrial partners as a way of influencing clinical practice and policymakers. And particularly as we heard there from that panel discussion, just how important it is to ensure diverse lived experiences, voices really underpin all of that. So thanks so much again. So now we're going to move on to our poster session. So this year we're doing something a little bit different, and MQ have organised a creative way for our poster presentations to help really make the research more accessible. And this is in the format of TikTok videos. So we're now going to watch 3 of those videos. If you have questions for the TikTok video presenters, if you can make a note of them, what we're going to do is after this, we'll move into breakouts, and I'll come back to that in a minute. And some of the presenters will be there and you can ask them your questions. So do make a note of them, but I'll now stop and hopefully pass on to the first poster.
A Partnership of Equals is co-production of a new family support service aiming to improve the mental health of children with a social worker. I'm Sharon Graham and I'm a parent with lived experience of social work. If we are going to create a new mental health service for babies and young children with a social worker, those wee ones need everyone working with them to form a partnership of equals. No family wants their child to come into care, and, as a group, children in care have much poorer mental health than their peers. The Independent Social Care Review in England calls for a revolution in family help to prevent children from coming into the system. We are trying to create this revolution. Our team of parent collaborators, clinicians, social workers and researchers is called Partnership for Change. We are co-producing a new service to support families whose baby or preschool child has a social worker. It aims to improve babies and children's mental health and avoid them coming into care. We interviewed 14 parents who were accessing a family support organisation, the Aberlour Trust, to find out what struggling families see as effective support. We found that when things went well, it was because parents and professionals set the agenda together. One said they listened to me and seen what I needed, and that was really it. It was down to me what support I needed, and they had a lot of stuff to offer. For the last 7 months, we have been co-producing our new service. We have conducted 5 focus groups with stakeholders, including clinical staff and 2 existing infant mental health teams, social workers and health visitors. We have qualitatively analysed transcripts of these focus groups and the notes of our meetings with parents, and we've extracted the key themes. We have found that generally assessments of families' needs are hit and miss. Clinicians tell us that. They get there late and people have not received anything like the economic support, housing, domestic violence, substance misuse, mental health or childcare support that they need. Barriers can be within parents or within the system. In our new service, some roles will be taken on by parents with lived experience, employed to help families, including joining a first home visit, supporting families in assessment activities and providing ongoing advocacy. In 2023, we will examine our new service in a feasibility randomised control trial. Parent collaborators will also develop a parent-reported outcome measure to measure what matters most to parents in a full-scale trial. If we can achieve this, then in the next 5 to 10 years, we could be seeing a real reduction in the numbers of children needing mental health support and having to come into care. Our study has already found that creating a partnership of equals is the best way forward.
If we want to improve our mental health, we need communities in which everyone can feel, I belong here. This is a mental health intervention. Our mental health is mostly about our circumstances. So this means our postcode is a better predictor of our mental health outcomes than our genetic code. But that's not how we currently think. Currently, we put the problem on the person. We know the limitations of clinic-based intervention. It's too short, difficult to access, focuses on numbers, and looks at things in isolation. But we know poverty, adversity, neglect, and toxic stress lie at the root of lots of these problems. And so what we need is an approach that can meet both of these needs. We need a trauma-informed approach to poverty.
On the project, there is a neighbourhood psychologist and a project worker, which is myself. We are working with groups of parents who have children under 7. We're using a 3-part learning approach. So the first part is a trauma-informed understanding of mental health. The second part is making meaning from experiences. And the third part is using a learning approach to create sustainable change and take action. What we're learning in the groups is that people want more than just medication, but they can't do it alone. It takes a village. For long-term intergenerational health, we need to help people and the community learn how to heal. It's emotive because it challenges strongly held assumptions that we have. It brings up emotions like shame, guilt, and those emotions are not easy for us to sit with. Our mental health is complex and it's messy, so what we need to do is we need to move at the speed of trust, we need to feel safe, and we need to feel heard.
For us all to have good mental health, we need healthy communities and healthy society. To do this, we must get it right for parents, to take a whole family approach that thinks about our circumstances and our relational health needs together. This is our hope for the Embrace project. We need to move towards a trauma-informed, system-focused, holistic understanding of what mental health is.
Those were absolutely fantastic. So huge thanks to all our TikTok poster presenters for those really wonderful and snappy talks on the importance of collaboration in mental health research and practice. I'll give you a big clap myself, as no one else can. So now we're actually going to leave this webinar and go into breakout rooms. So the breakout rooms will be an opportunity for you to meet some of the panelists, session chairs, some of the festival organisers and poster presenters, in order to further reflect on the topic of the day, and also to ask questions, particularly of the TikTok poster presenters. Because we can't set up the breakout rooms in this webinar format of Zoom, to join the breakout rooms, you should use the link that is now hopefully being put in the chat. Please make sure you copy the link for yourself somewhere so that before you leave this webinar, you don't lose it. If you click on it, you will be directed to a Zoom meeting. And there you will see at the bottom of the screen, you should see an icon that says breakout rooms at the bottom of the page. So from there, you can choose which breakout room you would like to join. And you'll have the option in that session to turn on your video and your mic if you want to actually directly ask a question in each of those rooms. If you go into a breakout room, you're welcome to choose to move to a different one if you wish. They've only got 10 minutes for these breakout rooms, so please do make the most of the opportunity. And please do not, when you leave a breakout room, don't leave the whole meeting. Please do just come back to the main part. We'll then wrap up the presentations of the day and discussion before closing the whole session and moving on. So hopefully in practice that's much easier than I've just described it. But if you go to the link in the chat, that should now take you to the Zoom meeting where you can choose your breakout rooms to carry on the discussion. So over to you. If you've got any questions, please do shout.